Professor Alan Fruzzetti. Professor Fruzzetti is a professor of psychology and the director of the DBT, Dialectical Behavior Therapy and Research Program at the University of Nevada in Reno. He received his MS and PhD from the University of Washington in Seattle, where he started his career and interest in DBT under the supervision of Professor Marshall Linehan. Dr. Fruzzetti's research focuses on the development and evaluation of effective individual and family treatments for problems related to emotion dysregulation. He is the author of more than 85 research and clinical papers and book chapters, and also authored 2 books. Dr. Fruzzetti is a research director and a member of the board of directors of the National Education Alliance for Borderline Personality Disorder, NEA BPD, that we heard from Perry Hoffman, who is here with us, a very important organization that is one of the co-organizers of our conference. He's also the co-creator of the NEA BPD Family Connection Program for parents, partners, and other loved ones of people with BPD. Dr. Fruzzetti is a member of the board of directors of the International Society for the Investigations and Teaching of DBT. In addition to maintaining an active pro bono clinical practice, Dr. Fruzzetti has created multiple DBT applications for individuals, couples, parents, and families, and has provided extensive training in the United States, Europe, New Zealand, and Australia in DBT, behavior therapy, and family interventions. I'm delighted to welcome Professor Fruzzetti for the first time in Israel to share with us his vast knowledge and experience on DBT. Please.
Good morning, and thank you so much for inviting me. It's absolutely wonderful to be here, and a pleasure. So I have an interesting task here to try in an hour or so to give you a tour of DBT. And it's a little bit like when you go to a new city and you hop on one of those double-decker buses and you drive around the city. You know, you get to look from the outside a little bit of the sense for maybe what's going on, but of course, that's all I can do is give you a brief overview. But I hope that the combination of some of the things I'll talk about this morning and some of the discussion we'll have following and some of the demonstrations on Sunday, maybe we'll get off the bus and walk around a little bit. Okay, so I guess before I start, I want to say that in dialectical behavior therapy, we have provided a foundation of theory as well as a set of clinical practices that go hand in hand. And it's very important in dialectical behavior therapy to be very clear about the underlying philosophy of science. And that philosophy of science leads me to want to say a couple things that might be a bit strange. One is, I don't believe anything I'm about to say to you. Okay? Now, I'm actually quite serious. What I mean by that is that we're talking about concepts. We're talking about theory. Theory is not reality. Our patient's experience is reality. But our concepts about their experience are our concepts about their experience. And that's in a concept world. So I don't believe what I'm saying is true, but it might be useful. In the same way that, no offense to what Frank is going to talk about, or people, I'm going to argue that what they're saying isn't true either. But what I'm saying isn't true also. So anyway, so now, anybody, if you still want to stay and listen anyway, maybe this will be a little bit fun. Okay, so what I want to do is divide my bit of time here into 2 sections. First, I want to talk about the treatment itself, and then I want to talk a little bit about research. So I want to describe the treatment, what we're doing, what the context is, what it looks like a little bit. And then I want to talk about what research tells us about DBT's effectiveness, and probably even more importantly, why DBT probably works as well as it does. Okay? So let's start with number 1. Let's start with the treatment itself. And what I'm going to do further is divide this into sections. And the first section will have to do with theory. What is our underlying, what we're going to call a transactional model, how we understand the problems of borderline personality disorder as being about emotion dysregulation. And then I'll also talk about the structure of treatment, the assessment that we do in treatment, and then of course the dialectic, which is acceptance and validation on one hand, and pushing for change and to do things differently on the other hand, which is all glued together with a dialectical philosophy. So we'll run through that and then we'll come back to some research. Okay, theory. So Dr. Silk earlier was talking about borderline personality disorder. And in DBT indeed was developed to treat borderline personality disorder, although not really. Actually, dialectical behavior therapy was developed to treat people who are chronically self-harming and chronically suicidal, who actually also tend to have borderline personality disorder or meet the criteria for it. So in DBT, we're not so overwhelmingly concerned with diagnosis. We're treating emotion dysregulation, and we would understand borderline personality disorder as being a prototype for chronic and pervasive problems of emotion dysregulation. So we treat people with borderline personality disorder as perhaps the most serious and chronic version of emotion dysregulation disorders, but we also would treat other people who are maybe don't meet the criteria for borderline personality disorder, but certainly have chronic and severe problems of emotion dysregulation. Okay, so now the way we understand this is, if we come back to borderline personality disorder, we don't say that borderline personality disorder causes emotion dysregulation, and we don't say that emotion dysregulation causes borderline personality disorder. This is one of those philosophy of science things. We say that borderline personality disorder is severe emotion dysregulation. Okay? Right? In the same way that, you don't say, gee, I don't know, what do you say? So that, to pick a different disorder, we don't say not producing insulin causes diabetes. Not producing insulin is type 1 diabetes. Right? And so we try not to fall into these tautological traps of saying that the things that are the disorder cause the disorder, right? Like trouble sleeping doesn't cause depression, and being depressed doesn't cause you to have trouble sleeping. Trouble sleeping is part of being depressed. It's part and parcel of the same thing. Okay, so emotion dysregulation, maybe graphically we think of as the centerpiece. Emotion dysregulation both causes the problems around the big circle, but is also caused by the problems around the big circle. So if you're chronically and pervasively dysregulated, you have all these problems: low self-esteem, problems in relationship. You start to develop emotion about your own emotion, because your emotion feels out of control, so you start to be afraid of having out of control emotion, which of course makes you have more emotion. And so forth and so on, including things like attempts to not feel so much negative emotion, okay? And like over here, but also things like suicidality and other impulsive acts which are designed to escape from serious, painful, negative emotion. So that's how we understand it. Now, of course, when you're chronically dysregulated, you get these other problems. They come out of being dysregulated. But of course, when you start using a lot of substances to manage your high, negative, painful emotional arousal, that of course causes further emotion dysregulation. So if I were better at PowerPoint, I'd have arrows going both ways, but I don't know how to do that. Okay, so we call this an emotion dysregulation disorder, borderline personality disorder. And the idea is that the maladaptive behaviors that people have that go along with having BPD, okay, those things have a function, and they function as attempts to regulate emotion. Okay, attempts, they function to regulate emotion. Now this is why we don't get overwhelmed in DBT when, I don't know about you, but in my clinic, our clients, our patients come in and they have an average of 6 diagnoses. They meet criteria for 6. Are these your folks? Okay. I have to say, having done this work now for 27 years or something like that, I still have not met a patient who only had borderline personality disorder. right? There are many other co-occurring disorders, as Dr. Silk talked about this morning. So rather than be overwhelmed by having a person with enormous suffering sitting in front of us with 6 or 7 or 8 diagnoses, we try to understand they have one core psychological problem, emotion dysregulation, that has manifestations in using substances to excess, sometimes self-harming, sometimes making attempts to suicide, sometimes binging and purging or restricting their eating, sometimes dissociating. Okay, and a whole range of relationships problems connected to those things. They cohere around emotion dysregulation. Okay, and most of those out-of-control behaviors like suicide attempts, self-harm, substance use, dissociation, they're attempts, dysfunctional ones, but nevertheless successful in the short term, to escape this chronic, painful emotion states of dysregulation. And sometimes, of course, other problems are natural consequences of being dysregulated, like developing fears of abandonment is a natural consequence of having chaotic relationships and having people abandon us. We develop fears of abandonment. So that's how we understand it. Now, the question is, okay, how do people develop these chronic and pervasive states of severe dysregulation? All right, now I want to be clear that dysregulation is not the same as being upset, okay? Dysregulation is an experience of being out of control. Whether one's behavior at that moment is truly out of control or not. Sometimes it is, sometimes it isn't. And it's on a continuum, okay? So emotion dysregulation is not the same as being upset. Now, I ask this question of everybody. Is there anybody here, I know, actually I've met a lot of people here, you're pretty nice people, but I wonder, has anybody ever said something mean and nasty to somebody you love? Anybody ever done that? All right, and about half of you are struggling with problems of truthfulness. Okay, and the other half I appreciate. Okay, that's nice. So that is, of course, from a DBT perspective, that moment when we say something unkind, something nasty to someone we love, that's a dysregulated moment, right? Because otherwise, how could we get ourselves to say something nasty to somebody we love, with whom we want to have a good relationship and we love deeply and we care about the person, and yet we say something that's probably a little more interesting than "you big jerk." We use much more interesting language in America, but you probably do too. So that's a dysregulated moment. So there's a continuum. We all get dysregulated sometimes. And I would say everyone does sometimes. Of course, borderline personality disorder is on the extreme end of the continuum. Chronic and pervasive dysregulation means that those moments when we feel out of control, and in fact may act out of control, are extremely common for people with BPD. Now, so there's not a difference in kind, but a difference in frequency and perhaps intensity. Now, so how do people develop this? Now this is actually an interesting and to some extent complicated model. So there's the first version, which is kind of easy. The idea is that people live in ongoing transactions in our social world. Okay, I don't think that's a controversial statement, right? We live in ongoing transactions in the social world. What I do has an impact on you, even right now, and what you do, at least those of you that I can see and hear, have an impact on me, right? And that goes around. And of course, probably more importantly, we interact with people that are close to us or that we're trying to be close to, and we have an impact on those people, and those people have an impact back on us, that kind of reciprocity. Okay, easy enough. So what happens is, the idea is that some people have a temperament that makes them vulnerable to getting dysregulated in the context of invalidating responses. Now, this is very tricky. It's not actually like a biological static diathesis, okay? Because it's not like that, because the idea is that our predisposition or our disposition changes over time. So, you know, if you're a person with a lot of sadness and you have caregivers as a child who actually also have a lot of sadness and actually have learned how to manage that sadness, you're actually in pretty good shape. You're probably not going to learn to get very dysregulated from your sadness. But if you're a person who's predisposed to having a lot of sadness, very sensitive temperament, okay, and you have caregivers who don't understand that, who don't like that, then when those children express some sadness, have an experience of sadness, they're left in the dark on the edge of a cliff because no one knows how to help them learn how to manage that experience. And of course what happens is because they're children, they're actually difficult to manage, and the parents don't understand, or caregivers don't understand, and so it actually makes the parents and caregivers respond in different ways because they're challenged by that, which of course makes them less able to provide what the child needs, which of course further dysregulates the child, which puts more pressure on the caregivers, who become less able to meet the child's needs, you get the idea. Okay, around and around we go. Okay, so that's the basic idea. Now I want to try to walk through this in a little bit more detail. Okay, so now this transactional model, remember I said earlier that we all get dysregulated sometimes? So this model would be a model that would make sense for any of us to understand at the moment when we are dysregulated. This model ought to fit, if this model is any good, but it also ought to explain pretty well what it's like to be chronically and pervasively dysregulated. So let's see if it works. All right, so it starts with an event, okay? Now, something happens, okay? And the something happens could be something that's private, like in your head, like you remember, I might have left the stove on, oh my gosh, you know, my goodness, I left the stove on, did I leave the stove on? So it could be a memory or a thought. It could be remembering something terrible that happened last week or 20 years ago. Or it could be something that's happening in the present moment. You know, you bump into somebody that you're happy to see and the person ignores us. That's an event. Okay, now that's a reasonably negative event, but it could be that we bump into someone we're happy to see and the person smiles at us and says hello. That's a positive event. So there's some source of emotional reactivity going on here, right? Something happens and we have an emotional reaction, heightened emotional arousal. That doesn't mean it's big or problematic, it just means we have emotion. And we're emotional beings, so this happens a lot, many, many, many times a day. Now that's one source of arousal. Okay, but there's more, right? A second source of arousal has to do with our vulnerability to getting highly aroused, okay? Now that actually is 3 different parts, at least in this model. Part 1 is temperament. Okay, how sensitive we are to emotional stimuli, how reactive, how big we react, and how long it takes for us to return to our emotional baseline. Those are dispositional factors. We call them temperamental. That implies that we're born with them and they stay fixed. That's not true. Data suggests that temperament is a slow-moving, but nevertheless malleable set of characteristics of people. And so temperament is part of it. The second part is our current biological disposition. Did we have enough sleep? Did we have enough to eat? If it's possible. Did you have too much caffeine? Okay? Things like that. And then of course there's our present baseline. If you left this morning and someone you love gave you a hug and said, I'm going to miss you today, okay, that's different than when you left this morning the person said, good riddance. Okay? I hope I never see you again. It's a very different kind of, so there's something going on that leaves us at a present level of arousal too. So those vulnerability factors provide a second source of arousal when something happens, right? We bring our baseline to the event, our temperament influences how much we respond to that event, okay? And our present biology influences how much we respond to that event. So if we're not very vulnerable, then arrow number 2 is pretty small, and most of our arousal simply comes from what happens. But if we're very vulnerable, actually, our vulnerability can contribute more to our arousal than the event itself. Okay? Now, one more source of arousal, which has to do with what we're going to call, in DBT, we're going to call judgments, which is a very specific way of appraising or thinking about implicit or explicit cognition, the ways that we think about cognitively, how we go in the wrong direction, there we go. How we think about the event itself, we can be judgmental of the event, ourselves, somebody else, what happened, or when our arousal gets high enough, right, this is something we've known for more than 100 years, when arousal goes up high enough, our ability to think in complex ways goes down, okay? And when if our stress and arousal goes up high enough, we actually become increasingly dichotomous or binary in our appraisals, which is what a judgment is. Something is good or bad, right or wrong, which has a very explicit kind of impact on our arousal and actually pushes it up, but also changes its quality. Okay? So, if somebody is chronically dysregulated, that means that A, they have a lot of negative events, things that are experienced in a negative way. They have a lot of vulnerability to those negative events, so those negative events actually result in a lot of arousal and a lot of emotional pain, and they become, at high levels of arousal, very dichotomous in their thinking, which feeds back and creates even more arousal. Whew, right? Painful. Yeah, okay. So, everybody okay with that? So that's the basis. That's the first part. Okay, and that's what's going on very quick. Now this whole thing takes, of course, a millisecond. Okay, this happens very quickly. Now, then what happens is, if a person's arousal gets high enough and painful enough, the idea is that the person then starts to engage in dysregulated behaviors, the function of which is to bring arousal down to less painful levels. Right? That could be any of these things and many, many others, okay? Now, at the same time, these behaviors plus other verbalizations are what we're going to call inaccurate expression, right? So if I bump into somebody in the grocery store that I'm very happy to see and that person absolutely clearly ignores me and doesn't want to talk to me, okay, that probably feels a bit sad to me. I'm a little bit hurt, disappointed about that, okay? But if I get dysregulated, if I have a lot of judgments and I'm highly vulnerable, I might say to you, did you see so-and-so? What a jerk. Or I might say to you, I'm such a bad person. Nobody likes me. I'm a terrible person. Either way, right, I've become judgmental of somebody else or myself, and that inaccurate expression makes it very hard for you to understand what just happened and what my first emotion, what my primary emotion would have been, which was disappointed. And if you happen to like the other person that I just said is a big jerk, you say, no, she isn't. No, he isn't. Or if you're trying to be kind to me, you say, you're not a jerk at all. No, people like you. Okay? Or you say, you shouldn't feel that way, or you do something that we actually call invalidating. Okay? Mary Zanarini, a top researcher in BPD and other things, says it's very hard to understand when someone's hitting herself in the face with a hammer. It's hard to understand that that's a way of expressing loneliness. You don't see it in that behavior. You don't see in self-harm. You don't see in dissociation, I'm really sad and disappointed about what happened. And so people respond in ways that are very invalidating, like you're crazy. There's something wrong with you, because of course they don't see what happened. They don't see the person's temperament. They don't see their biological vulnerabilities. They don't see the judgments. They only see the I'm going to put this in quotes, the crazy behavior. It's not crazy at all. It makes sense if we understand the context, but it sure looks crazy because it's inaccurate. Okay? And of course, does anybody like being invalidated, by the way? Is that something that's like one of your favorite things to do? Probably not. I'm just going to assume that. And so what happens is when somebody gets invalidated, that pushes our arousal up further. Okay? And now this, of course, doesn't take very long either. And then this goes around for a while. This twitches and feels terrible and feels terrible and feels terrible. And of course, the person then might go off to that other slide and engage in self-harm or dissociate or binge and purge or whatever. And of course, if this happens often enough, it creates a pervasive, ongoing pattern of invalidation, which in turn creates more sensitivity, more vulnerability. Okay? That's our model. Now, if that makes sense to you, okay, and I hope it does, then you get the whole map of DBT interventions, because DBT has intervention strategies for each box in this map. Okay, DBT is going to address how to help people reduce their vulnerabilities in all ways. DBT is going to help people problem solve so they have more positive and fewer negative events. DBT is going to help people reduce or eliminate their judgments and become more descriptive. Going to help people manage or modulate their rising emotional arousal. It's going to help people express themselves more accurately, validate themselves, and seek validation from other people. Okay? So DBT is going to be all over this map from an intervention standpoint. Okay, so that's the theory. That's it. Easy, right? Okay. All right, so let's talk about structure for a minute, because DBT has a structure. And dialectical behavior therapy is, I want to say, is different from many other psychotherapies just based on structure. That we have not just one mode of treatment, one-on-one individual psychotherapy, but we have 5. Actually, 5 functions of treatment. That doesn't mean we have necessarily 5 entire modes of treatment, but 5 different things we're trying to accomplish in DBT. And if we don't do all of them, we actually can't say it's DBT. It's a piece of DBT. It's a little bit like having a surgical suite, you know, without an anesthesiologist. I don't know, do you want to have triple bypass surgery without an anesthesiologist? Probably not. Okay, you might, you know, but you're right, we give the surgeon some credit, but, you know, I think the surgeon needs the anesthesiologist. Or how about a janitor? How about somebody to make sure that the operating suite is clean? Maybe it seems not too important, but do you really want to do this on the floor, on your kitchen table? Probably not. So there are different parts and they each have a role. So, and this is not in any particular order, but one component of DBT is enhancing capabilities. Because this is a model that understands people as having problems regulating their emotion, and we see helping people learn to regulate their emotion as the core target, then we have, of course, have to teach people how to manage their emotion and their relationships and their attention and their distress. Okay? And so we call that skills training. And we have a manual for that. There are different kinds of psychological skills we help people learn. And that's an important piece of it. We most often do skill training in groups, but one could do skill training individually if you wanted to. Okay, a second piece has to do with understanding and trying to increase the motivation of our patients to act more skillfully when they need it. Okay, on the road to dysregulated emotion and dysregulated behavior, it's how to manage the events and the vulnerabilities and the emotions differently to end up at a different place. Now, motivation in that sense is typically done in individual therapy, and we're going to use something we call a chain analysis, okay, a way of unpacking dysregulated behavior. And we're going to provide a lot of support and validation of the valid parts and a lot of push to do things differently. And I'll come back to that in a minute. Okay, a third piece has to do with generalization. Okay, in behavior therapy, we talk about learning a skill, you know, like learning to drive. Okay, one of my kids, I've got 4 kids, one of my kids is learning to drive, and it's one thing to read a book about driving, to take the written test about driving, and maybe even drive around the parking lot where there's nothing to hit, and it's another thing to go out on a busy freeway during rush hour, okay? He's at the parking lot stage right now, and I'm one rear view mirror short on the car. So, but anyway, so generalization means you're taking it from the learning laboratory where you intentionally create easier circumstances to learn, right? We teach people to swim usually in a swimming pool that's 1.5 meters deep, that's not 10 meters deep, okay? And we teach people to drive in a parking lot that's open and doesn't have things to hit. But then we at some point have to get people out onto the road and into traffic. Okay, and so we help people do that. Now in DBT, we have a lot of ways to do that. Mostly we do it by practicing in the session. Mostly it's what we would call rehearsal, okay, planning, generalization planning, but we also are available to patients to some extent in between sessions, recognizing that, you know, the 1 or 2 or 3 hours of in-session time that we have a week maybe isn't enough. Sometimes people need help the other 165 hours a week. And so we're available sometimes by telephone, sometimes by SMS, or other ways of intervening. A fourth component has to do with ourselves. You know, what Dr. Silk said earlier in DBT is axiomatic, the idea that we are influenced by the patient in the same way that we're trying to influence the patient. And we better have help staying balanced in how we're going to do that, and so we have a team. And in DBT, a team is not something, consultation and supervision is not something that happens when you start, but it's something that goes on forever. We never grow out of our need for ongoing consultation from our peers. And that consultation has to do with both our abilities to be skillful and deliver the treatment well, but also our own motivation to do so. We have to like it. In DBT, we have to like doing DBT. All right, not every moment, okay, let's be clear. But overall, we have to like it. It doesn't do much good to be really good at something that you hate doing, right? Then we burn out, we quit it, we go sell insurance instead. Okay, not so useful for our patients. On the other hand, it's not so helpful to our patients if we love what we do and we stink at it. Okay? We're delivering lousy treatment. We love delivering lousy treatment. That's not so good for our patients. So we have to do both things. We have to like it and we have to be good at it. And in DBT, we have very explicit guidelines for what it is that's within the boundaries of treatment and what's outside the boundaries of good DBT. And then finally, we recognize that our patients don't live in a vacuum. They interact with other people all the time, friends and family, and they have a very significant role. Friends and family can be very invalidating. We want to help them be less invalidating. Friends and family have the potential to be extremely validating. We want to help them be more validating. We also want friends and family to be motivated by the patient. We want the patient to be loving and kind to their family members. And we want the family members to be loving and kind and decent to the patient. So, if it has all 5 components, that's DBT. So if somebody asks you what DBT is, this is the shortest slide I got. Okay. Now, what organizes the treatment? Well, we have what we call a treatment target hierarchy. Okay, what does that mean? That means that, remember I said that in my clinic, our patients have an average of 6 diagnoses. Okay, I think it's 6.5 actually. Well, we don't organize our thinking diagnostically. We organize our thinking in terms of severity. So we treat the out of control, most dangerous things first. Okay, well, we organize this in stages. We call this stage 1. Stage 1 has to do with safety and stability. People come into treatment, typically DBT patients come into treatment when they're doing things that are scary, they're unsafe, they're out of control. If they're adults, they may be self-harming or making suicide attempts, or maybe aggressive towards others, or all of the above. If they're teenagers, they may be doing the same things. They may be not going to school. Adults might not be able to go to work. These are out of control things, like, not able to do. So safety and stability, things that are life-threatening or interfere with the ability to participate and get something out of treatment, or are severely interfering with a very minimal quality of life. And that's our first set of targets. Now, I put a little asterisk here because I think that lots of people who are walking on the wall looking into DBT, or who are riding that double-decker bus, think that that is DBT, is just safety and stability. And that's a cartoon, because that's not what DBT is. That's what DBT is in the beginning when people are really out of control. But as people gain more self-control of stability and safety in their actions, they move on to addressing more misery, right? Because a person could be miserable, but still able to drag him or herself to work or school, still able to maintain some active relationships. They may be chaotic, but they could just be miserable a lot of the time. And that's certainly a bona fide treatment target. We call that stage 2. When the person's not doing things that are dangerous to themselves or others, is actively able to participate in treatment, and isn't so substance abusing or eating disordered that they can't function minimally in life with some structure. Okay? And so that's stage 2. Now below stage 2, we could probably draw a line here and say that's probably stages 1 and 2 are more clinical stages, where people have problems that are severe enough to meet diagnostic criteria for severe disorders. But that doesn't mean that somebody couldn't still have difficulties, ordinary problems in living, and we could treat those in DBT in the same ways. And although we don't do it very much, there's a stage 4, which is, okay, now the problems are gone. Stage 3 is really like trying to problem solve your life and make your life better. Stage 4 is, okay, now you've problem solved. Now can you, stage 3 is how can you get what you want? How can you get what you get? Now, many patients stop treatment after stage 2 because it's not they're no longer clinically at a level where, you know, maybe insurance pays for treatment or they feel so much better they're out of treatment, but some patients stay in treatment longer into stages 3 or even into stage 4. Okay? And of course, therapists and clients are collaborating on those targets even though there's a hierarchy. There's still a lot of collaboration about what our targets are and what we're working on. Okay. The overarching goal of DBT, of course, is creating a life worth living. And I want to point out that the overarching goal of DBT is not keeping people alive. I also want to point out, you can't have a life worth living if you're dead. Okay? It's very hard. I don't know anybody who does that anyway. So you've got to stay alive, but that's not the point of the treatment. Okay? In the same way that staying maybe out of hospital is not the point of treatment. But it's hard to have a really high quality of life if you can't function outside a psychiatric facility, you know. So it's also important to be able to help people live in their lives in the real world outside of a hospital, those kinds of things. Okay, now there's also there are change and problem solving strategies that I want to talk about for just a minute, and then we'll talk about acceptance strategies. The change and problem solving strategies come mostly out of CBT, behavior therapy. And in modern behavior therapy, we can think of there being different things like, okay, we have to do some assessment, we have to understand problems. We do a chain analysis, which I'll show you in a second. We teach skills, okay, because skill deficits are part of the problem, so learning skills are part of the solution. But I also recognize that sometimes there are stimuli in the person's world that are so problematic that we have to recondition them. That's a very kind of funny term maybe, but you know, for example, someone who's had severe trauma, maybe physical or sexual abuse during childhood, maybe 20 years later, some cue of that trauma comes up and the person reacts as though that person is in that dangerous situation again. Now from a DBT perspective, that's a problem of stimulus control. The person's brain misidentifies the stimulus of remembering abuse as being present abuse, which it's not. A memory of abuse isn't dangerous. It's awful and unpleasant, but it's not dangerous. Being abused is dangerous. They're quite different. And so we do trauma treatment, we do all kinds of exposure things around stimulus control. There are also contingencies or consequences that shape behavior that are maladaptive, and when we have that kind of situation, we want to recalibrate. We want to change those consequences to shape more effective behavior. And of course, we do exposure and response prevention. We teach a lot of mindfulness, acceptance, and validation, self-validation. So there are different change strategies, including acceptance strategies in the face of non-acceptance. Okay, so learning to self-validate when one is self-accept, when one is not self-accepting, of course, is a change. It's a dialectic. All right, so when I say chain analysis, some of you might know what I'm talking about, but basically a chain analysis is a way of unpacking a set of problems. And so maybe in this example, the patient cut her or himself on Thursday at 4:30. Okay, that's in the afternoon. That's the target behavior. That's a dangerous behavior. Maybe it was a suicide attempt, maybe it was a self-harming, non-suicidal self-harming event, or some other, but let's just use an example of self-harm here. So in DBT, we want to understand this, but we want to understand it primarily in terms of proximal causes. Okay? So it might be that this person cuts him or herself, and there may be long-standing historical things. I had a patient who, she cut herself and said, well, gee, you know, my mother used to cut herself. And so we could say reasonably, okay, there's some learning that went on there. But at the same time, her mother cut herself, you know, 30 years ago. And this particular patient cut herself Thursday at 4:30, but not on Wednesday. On Wednesday, she had a mother who had cut herself too. So what's the difference between having a mother who cut herself on Wednesday, and she doesn't cut herself, and a mother who cut herself on Thursday, and she does cut herself? In DBT, we would say the mother who cut herself is really a pretty distal factor. It doesn't help us understand why she's cutting herself on Thursday. Not very much. So we have to look at other factors, more proximal factors like her present vulnerabilities. And what happened? Something happened. And then how did she react to what happened? Okay, now in this particular example, maybe there's a trigger. Maybe, so I'll give you a real example. So a client recently, she had some plans, pretty lonely client, not a lot of friends, and she had some plans to do something with a friend, I guess on the weekend or something like that, was really looking forward to it, and then got an SMS from the friend saying, sorry, got to cancel our plans to go out. And now, pretty reasonably, that trigger, okay, elicited some sadness. Now, can you see that's a pretty normal thing? If I said that happened to me, and I said, oh, I was disappointed, you would say, oh, you must have borderline personality disorder. You'd say, of course, sure. Everybody, you know, you're looking forward to something, seeing an old friend, the friend cancels, you're disappointed. That's pretty normal. And if it stopped there, and the person managed her sadness, no problem. But that's not what happened. After a while of feeling sad, she started to judge herself. I'm worthless, I bet my friend just didn't want to spend time with me. And then, of course, that kind of self-invalidation created a secondary emotion. Now I'm feeling ashamed. I'm a bad person. I feel ashamed of myself. And I drew this as though there were just 3 pieces here. But this went on for an hour and a half and just spun around. And she spun around and spun around with this over and over and over again. And then felt so completely out of control and miserable that it occurred to her that, oh, you know, I should hurt myself. I deserve it. I'm a bad person. And plus that gives me some relief. So she cut herself. Now, this is just a simple example. We could make it more complicated. But that's how we would come to understand the proximal causes of her self-harm. Okay? And then we would say, in order to treat this, there are a lot of ways to do it. Okay? We can teach skills to create choices. Okay? If we can teach her how to have more friends, it's not so devastating to have the one friend cancel. That's a possible solution. If we could teach her how to handle sadness better, that would be a solution. If we could teach her how to handle judging herself in a different way, that would be a solution. So what happens is we try to break that chain anywhere we can before the self-harm. Now, early in treatment, to be honest, early in treatment, we're often just dealing with the early parts of this chain happen so quickly, the patient may not have any awareness even of the sadness. The patient just may originally just immediately feel overwhelmed with shame or anger or flip back and forth. And early in treatment, we might simply help manage that emotion without self-harming. And then as the patient gets better at doing that, we might move backwards on the chain to help manage the emotions back here. Build other kinds of relationships and other skillful behaviors to get off this dysfunctional chain and on to a more skillful one. That's the idea. Now, my limited PowerPoint experiences are showing themselves again. So this is supposed to signify the red light therapist says stop these things, the green light therapist says do these things, okay? So the therapist in the session, because in the session, it's not just talking about what happened on Thursday at 4:30, but also talking about it could elicit some of the same things going on in the room. So when those same emotions are going on in the room, the same judgments, the therapist has the opportunity to try to help block and understand these things and channel and encourage and coach the person to do things differently right there in the room. And then, of course, transfer whatever works, okay, whatever leads to relief that's skillful, to transfer the same set of skills out into daily life. So there's this ongoing, iterative process back and forth between what happens in the room to what goes on out of the room in the patient's day-to-day life. Back and forth, back and forth. We bring things into the room that happened yesterday or last week, and solutions that develop in the room, and put them out into the person's week next week. Okay, so that's the change part. But of course, along the way in this dialogue, there are 2 real people transacting, the therapist and the client. And the therapist and the client have to develop in DBT a real relationship as 2 human beings, which of course includes the therapist expressing a lot of acceptance and validation for the patient. But it's acceptance and validation for the valid experiences and behaviors of the patient, and validating valid behaviors in the ways that they're valid. Okay, can you say that fast? Now, simple example, okay? Maybe not trivial. So imagine that I had a car accident. This isn't true, I'm making this up, but imagine I had a car accident last week, okay? And I got really shaken up and bruised, and you know, I've had some sleepless nights and a little bit of some nightmares about it. And I go to get in the car with you, and I start to shake. And let's imagine that you're I don't know you, but let's imagine you're a safe driver, okay? That I've never been in a car crash with you, and your car looks pretty good. It's got no dents, okay? So what do you say to me? Do you say, what do you say? Do you say, gee, Alan, you know, this is a pretty dangerous situation, you know? Or do you say, of course you're anxious because of the car accident, right? So there's one way in which my anxiety, my fear of getting into the car is valid. It's valid because of my history. That was a car crash last week. And there's another way that it's not valid. It's not actually dangerous right now. We're just walking across the parking lot. Nothing bad is happening right now. I'm just going to get in the car and drive 1 kilometer, you know, go have lunch. That's not particularly dangerous. And so you're going to validate it, my anxiety, my fear, only in the way that it's valid. Not in the way that you don't say, of course you're scared, I'm a terrible driver, if you're not, okay? Now, we do quite the same thing in DBT. We have to sort out what's valid and what's not. Now, the good news is that validation is a very potent thing. I'm not going to go through the details of this study. It's published if you're interested, but we stress people out because we're a little bit sadistic, okay? And I'm on the ethics board, so it's okay to do it. But we stress people out. Now, in all seriousness, of course, these people are volunteering and they know that they're going to be stressed out. We stress them out, and then what they don't know is they've been randomly assigned to being validated or invalidated while they're continuing to get stressed out. And what happens is, not surprising, probably my grandmother's study, because my grandmother, if she were alive, she would say, "They paid you to do this? I could have told you this." And of course, she would have been right. She could have told me this, and so could you, but they didn't pay me for doing this, so why wouldn't I do it? You know, so what happens is, not surprisingly, when the person gets invalidated, the red line, the person's stress level stays very, very high. But when they get validated, even though there's ongoing stressful activity, when they get validated, their stress comes down 2/3 to 3/4 of the way. They actually get soothed, and their arousal comes down, even though the stressor never goes away. The stressor is ongoing throughout the entire experiment, okay? But people who get validated tolerate the stressor. Notice how the stressor isn't an objective thing. The stressor is in transaction with the person. Okay? Now, we replicated this a couple times, including looking at whether people with BPD have different responses to this kind of scenario than people without BPD, and the pattern's exactly the same. The only difference is the people with BPD, they start here. They start at high levels of arousal before the experiment, okay? But the pattern is the same. It goes up, and if you validate people with BPD, the arousal comes down. If you don't, the arousal stays up. It's quite the same. Now, we validate in ways that are both verbal and explicit. We have a whole bunch of ways to do that I don't have time to talk about. And we validate functionally, like doing things in response to what's needed. And we call that implicit and functional validation when you do what's needed. Okay? Now, the idea here is that we're going to balance the acceptance and validation part of our treatment with the change part. So we're going to, on the one hand, accept and validate and be warm and caring around the valid things, and we're going to be pushy and irreverent and downright difficult sometimes around things that need to get changed and be different, and we're going to balance that dialectically. Now, a dialectical balance includes a lot of different things. It includes balancing doing things for the patient as opposed to coaching the patient on how to do things for him or herself. Now, we defer to the coaching part whenever possible, but sometimes we have to intervene for various reasons. We have rules about that. We balance our interpersonal style. be very genuine. And genuineness, if you think about how do you interact with your brother or your sister, you know, sometimes your brother or your sister is acting in ways that are a little crazy. You say, what is wrong with you? What are you doing? What were you thinking? In DBT, we do that too. Okay? What is wrong with you? Okay? This is a perfectly legitimate thing to say in DBT. I know it's not the standard that you think of as mental health professionals, but in DBT we can do it. But we balance it with warmth and caring. It's also very genuine. And they both come out of an authentic, genuine place. So we have a real relationship between two real human beings where the therapist brings a lot of compassion and caring, and the team helps the therapist maintain that position. But part of compassion and caring isn't just saying, I understand. It's also, and you got to cut this shit out. Ooh, can I say that? Yes, I just did. So, like, we've got to do something different. We can't just soothe and support. We also have to say, and you're in so much pain, we've got to get you out of this situation. We've got to help you change it. If we're really compassionate, we're both going to be warm and loving in one sense, but we're also going to push for change in the other sense. And that's part of the dialectic. Okay? All right. That's DBT in a nutshell. Whew. Now you're ready to go do it, right? Yeah. Okay. So the question is, how well does this work? And if it does work, why does it work? So I want to spend the last few minutes to give you a good tour of, I don't know, 75 studies, okay? Not in any detail, don't worry. Okay, so what I want to talk about is actually four kinds of research. One are just basic outcomes. The second is comparative outcomes. One is how well does it work just within DBT. Second is how well does it work compared to other treatments. Third, what are some of the mediators? What are some of the things that psychologically have to change to get good outcomes, not just in DBT, but in other treatments, so that maybe are core processes of change with severe dysregulation in BPD. And finally, what's actually going on in the room? And how might that relate to outcome? Okay, so I'm going to give you just a little taste of each piece of this, starting with outcomes. Now, I'm not going to read this to you. Let me just say that in DBT now there are many, many, many studies. Okay, I don't know how many studies, maybe 50, 75 studies of outcome. About 25 of them are controlled. Okay, about half of them are with explicitly BPD patients. The other half are people with BPD features, but not necessarily full-blown diagnostic BPD. And these are studies with adults, with teenagers, with older adults. They're for outpatient settings, inpatient setting, residential settings, day treatment settings, and forensic settings. All kinds of places, all kinds of problems, all kinds of co-occurring diagnoses. What do all the studies say? Every single one says there's a significant improvement with DBT. Now, some of those, I'm only talking about DBT studies that have all five, they're real full DBT. Now, there are also another set of studies where we're using parts of DBT, and that's a different story that I'm not going to talk about. So the outcomes are very consistent across studies, and DBT is very good at these out-of-control behaviors. Now, the problem with this literature, okay, they're very good for outcomes like self-harm and dangerous things, very good for co-occurring disorders, very good at reducing dropout, okay, like internationally, outpatient dropout is between 16 and 20%. Other treatments, it's anywhere from 30 to 80%. So, and costs are reduced by 50%. So even though we've got all these functions and a lot of stuff going on, it's actually cheaper to give people a treatment that works than to give people a treatment that doesn't work very well. Now, the problem with this, and I just want to be clear, is I don't want to imply that DBT is a perfect treatment, because it is far from perfect treatment. Okay, 1/3 of people who enter DBT get no benefits at all. Okay, they don't get benefits. So if you're in that third, DBT is a lousy treatment. Now, if you're in the other 2/3, DBT ranges from an okay treatment to an extremely good treatment. So it's not let's be a little bit complex in our thinking. So we know, I think it's reasonable to say that DBT works reasonably well, okay? The question is, what about the details? Well, it's statistically significant improvement doesn't tell us everything. How many people don't improve? Well, about 1/3, okay? We know that. How many people get a little bit better but not entirely better? Well, it depends. It depends on how long they're in treatment. Unfortunately, in the United States, our treatments that are funded research treatments are limited to 1 year. Now, 1 year is a lot of treatment on the one hand. On the other hand, for people in our clinic have typically anywhere from 8 to 20 years of severe problems, 1 year of treatment isn't always enough. So in our clinic, which is, we're doing ordinary outpatient work in our outpatient clinic, in our teen program for residential, you know, we've got kids who have had problems for a long time. Without being constrained by 1 year, our folks are in treatment an average of between 1.5 and 2.5 years. Now, if you let people be in treatment that long, the proportion, whoops, sorry, back, the proportion, whoops, the proportion, oh, more time, the proportion who get better but not entirely better goes down, the proportion that get recovered goes up. But if you end treatment at 1 year, it's about 1/3, 1/3, 1/3, roughly speaking. If you have a very severe sample to start with, about 1/3 don't get better at all, about 1/3 get a lot better but still aren't fully recovered, and about 1/3 are fully recovered and don't really relapse. They do very well. If you let treatment go on longer, and I have to say this is without much controlled data because we can't get funding for that, that proportion of people who are better but not all better goes down and the proportion of recovery goes up. So we need more studies. We have to understand that. Okay. Said that. There we go. So, consistent outcomes, medium to large effect sizes, and so forth. So pretty good. We need longer treatment studies and longer follow-up studies. The follow-up studies that we have tell us that there's very little relapse, at least within about a year of the end of treatment. But of course, we need things like 5-year and 10-year follow-ups to know if those improvements are enduring. We just don't know. All right. Now, comparative outcomes. DBT has been compared to a lot of things. Most commonly, it's been compared to ordinary outpatient treatment as usual in outpatient psychiatry. Now, honestly, that's a pretty lousy comparison because across the whole universe of psychotherapy research, any specified treatment typically works better than treatment as usual, which is non-specified, non-specialty treatment. And that's part of, I think, what Dr. Silk was talking about earlier, that specialty treatments have better outcomes than non-specialty treatments for severe problems. And I think that's a reasonable summary. In DBT, we know that DBT works really well compared to what? Well, let's have a look. There are two things I'll just use to summarize. One is the American Psychological Association has standards for what it calls empirically supported treatment, which are actually not very high standards. They have to have at least 2 randomized trials. At least one of them has to be conducted by somebody who doesn't have a personal stake in the outcome, you know, didn't develop the treatment, so there's more objectivity. And the preponderance of evidence has to be consistent good outcomes, okay? And actually, DBT is the only treatment for borderline personality disorder that meets that standard at the moment. That's going to change soon. Mentalization, I think, within the next time a randomized trial of mentalization is published that's not been conducted in the UK is probably going to end up on that list pretty soon. And that's very good news for patients because patients need, you know, don't forget DBT's failing a lot of the time. Patients need different kinds of treatments. A Cochrane report, the Cochrane review by Stoffers, concluded that DBT is the only treatment that has had enough research to actually be conclusive that DBT works for BPD so far. That may change. I hope it changes, but at the moment, that's the case. Okay, now, what's going on? What's responsible for these outcomes? Well, I'm going to present a few different kinds of windows into this outcome, and let's see what you think. Okay, now one, I want to present a study, a randomized trial that we did in our setting for young adults, 18 to 25, who are self-harming and suicidal. Okay, and I'm going to show you a few slides of outcomes comparing DBT to psychodynamic psychotherapy. Psychodynamic psychotherapy in this case was an object relations-based treatment based on a published manual, and part of the reason that we did that particular comparison group is because we were lucky enough to have the author of the manual, an expert in treating BPD from an object relations standpoint, actually living in our city, who was willing to train therapists and supervise them. So we gave her carte blanche. She could do what she wanted. We controlled for the number of hours of training and the number of hours of supervision, and controlled for a bunch of other things. And so this is a pretty reasonable comparison. Now, to be honest, our interest was not as much, gee, which treatment works better? Our interest was really to understand why, okay? So the short answer is they both actually showed significant improvements, both treatments. This was a decent treatment. The psychodynamic treatment outcomes were actually pretty good. In DBT, outcomes were better. Okay, this is on suicidality using something called the Suicidal Behavior Questionnaire, an interview, and both treatments showed significant improvement. Improvements were better in DBT. On depression, we see the same pattern. Both treatments showed significant improvement over time. By the way, the treatment was up to 12 months, not longer than. The average length of treatment was about 9 months. And then there was a follow-up period, another 6 months. And so as you can see, both treatments showed significant improvements in depression, measured by the Beck Depression Inventory. DBT, significantly better improvements, okay? And in fact, these outcomes, it's very interesting. Compared to the literature, these psychodynamic outcomes, the red line, are actually much better than most other published results. So this is a pretty decent treatment. And the outcomes in DBT are right into the normal range on average. So these are extraordinarily good outcomes. In terms of global assessment of functioning, you know, Access 5 in the DSM, as you can see, our folks are starting down here, averaging around 50. It's not really very well functioning, and showing significant improvements up to about 65 in the psychodynamic condition, and up to about 77 in DBT. So both improved significantly, DBT more so. And finally, whoops, in terms of social adjustment, I'm not doing a good job with the clicker here, sorry. Social adjustment, the same deal, both treatments showing significant improvement, DBT showing better reductions in social problems, more social adjustment at the end. All right, so those are the outcomes, okay, just keep that in mind. So both treatments working pretty well, DBT working a little bit better. So the question is why? Now a mediator says that that's the pathway to a good outcome. And a true mediator means that it doesn't matter which treatment the person's going through, they still have to go through that pathway, okay? It's like a mediator says that you have to change that. You have to improve that to get out. Now, there might be different ways to do it in different treatments, but you've got to improve it. So one outcome, one mediator that we're interested in from a DBT perspective was emotion regulation. Gee, can you improve emotion regulation? And you have to do that to have a good outcome. Well, it turns out yes. That in fact, as you can see here, emotion regulation, or problems with emotion regulation, went down, or emotion regulation went up in both treatments, more so in DBT, and that mediated the outcome, which meant that regardless of which treatment the person was in, and for those of you who are statistically minded, you co-vary out treatment first, and then you say, okay, regardless of which treatment the person's in, if they get better on emotion regulation, does that predict outcome? And especially early, we call this temporal relationship. The temporal relationship is you have improvements in emotion regulation early, and that predicts outcomes later on. And the answer is yes, yes, yes. Emotion regulation seems to be a central process. Okay, that's interesting. Well, it turns out that another process is also relevant here, family distress. Now, this is a particularly interesting one because there was really no family therapy in this study. Okay, this was almost entirely individual therapy, and yet family functioning, family distress went down in both treatments. Okay, there seemed to be a little relapse going on in the follow-up, but they went down in both treatments, more so in DBT, and family functioning also mediates outcome, meaning that regardless of treatment, if patients' family and functioning didn't improve, they were very unlikely to get better themselves. Now, this was only true for suicidality and not so much for depression. Interesting, okay? There's probably more we could talk about that one, but for suicidality, family functioning is very important as a mediator of outcome, which suggests, of course, the possible utility of adding family interventions to any treatment. Okay. Now, what about the therapeutic alliance? This was the, emotion regulation comes out of a DBT hypothesis, but of course in the psychodynamic condition, the question was, well, they would say, and they did say, well, we think that it's going to be mediated by the therapeutic relationship. And everybody knows the therapeutic relationship is responsible for outcome, right? Everybody knows that. That's axiomatic, right? Well, it shouldn't be, because it's not true. Now, don't shoot me yet, okay? Look at this. Okay, so DBT, does this look familiar now? So now the red line is the patient's perspective on the therapeutic alliance using the working alliance inventory, standard measure in the field. And this is actually pretty good, pretty standard published results for a therapeutic alliance, pretty decent. But look, DBT alliance was stronger at every measurement point. Interesting. Huh. How could that be? We're so pushy. We're so difficult. Yet the alliance is pretty good. Well, I'll come back to that. But so the question is, okay, does that mediate outcome? The answer is no, it doesn't. Within treatments, the quality of the alliance is very related to outcome within the psychodynamic treatment, but not within the DBT condition. So it's not a true mediator of outcome, which means that if you're doing psychodynamic treatment, at least this version, you better have a good alliance to get a good outcome. If you're doing DBT, you know, everybody's got a decent, better alliance doesn't matter. It's good enough. Whatever that is good enough. So what does that mean? Well, it means that in DBT, we don't wait to build a good alliance to do other things. We see it dialectically. We say doing other things builds an alliance, and that's nice, but doing the important things is the work. The alliance is a side effect in DBT. Doesn't mean that's true for other treatments, but in DBT that's true. In DBT, the alliance per se is not predictive of outcome. So it's not a true mediator. It's interesting. Okay. So what about from other perspectives? You know, well, there's a study of looking at DBT compared to BPD experts, who are mostly psychodynamic therapists. And this is kind of interesting. So using psychodynamic scales, observation scales, looked at things like positive introject, self-affirmation, self-love, self-protection, less self-attack. DBT actually showed greater improvements on these psychodynamic scales than the psychodynamic treatment did. Well, that's interesting. Well, that means that maybe these things actually are relevant, but there's more than one way to get there. You don't have to go through a psychodynamic treatment to have a psychodynamic outcome. Well, does that make you feel a little tweaked? I hope so. Okay. Now, last thing, I have 2 minutes, and that's, I think, just enough time here. So, the process of change. So the question is, what's going on in the room? So we just picked one part of this. This is a dialectical treatment. It's got a lot of parts, but we just decided, well, let's look at validation, because validation is something that's common across just about every psychotherapy includes some version of validation. So we said, okay, so we took a bunch of non-therapists to rate sessions. We have videos of the psychodynamic treatment, videos of the DBT, non-therapists, non-biased. We train them to identify different ways that therapists validate, to identify what the patient is doing when the therapist is validating. And we randomly pick a couple of sessions from each patient-therapist dyad. Okay, and that's what we're doing. And then we're interested, well, how is what the therapists are doing the same, and how might it be a little bit different? Okay, so all I have to do is get this to work. There we go. Sorry. Base rates. If you lump all the ways that we could validate together, we see that psychodynamic therapists and DBT therapists validate at the same rates. And if we only did that, we might make a really faulty conclusion. Because in reality, what the therapists validate, when they validate, and how they validate were very different. But both kinds of therapists are validating on a regular basis. But DBT therapists are more likely, 8 times more likely, and for any of you researchers, you know, something where it's 8 times more likely is a little bit unheard of, but 8 times more likely to validate using a normalizing approach. Now, normalizing means, remember I said earlier, if I told you I'm supposed to go have dinner with a friend, and you know, my friend called or left me a message saying that he was canceling for tonight. I was so disappointed. And I suggested that that's normal. Okay? In DBT, we normalize that. Well, it turns out in the psychodynamic condition, they were less likely to show emotion and say, oh my gosh, of course, that's so disappointing. DBT therapists say, oh my goodness, that's so disappointing. Of course you'd be disappointed. In the psychodynamic condition, they said, so you were disappointed. Now, I decided, being a scientist. I said, well, what do good scientists do? Well, I said, we got to have a little focus group. So I got together some young people and said, okay, I want to try to validate you. I want you to tell me how this feels. I want to try to do different things. So the first one was, I said, I'm just going to reflect. You know, here's the situation. And I reflected. I said, well, it seems that you feel disappointed about that. Okay, and so here's what their response was. Okay. And I said, okay, well, let's try it differently. How about, of course you feel that way. Anybody would feel that way. I know, it's shameless to show you pictures of my children, but I did it anyway. Okay. So, it's DBT. I have no shame, right? I've managed my shame. It's okay. So the missed opportunities is sort of an interesting idea. It's not just what they are doing, but what they're not doing and when they're not doing it. And the psychodynamic therapists were less likely to validate those primary emotions. So in this example of the client who was very disappointed about the plans being changed, but ended up feeling overwhelmed, flipping back and forth between being angry at the friend and ashamed, okay, the DBT therapists were more likely to include some focus on the sadness and disappointment and how to stay with that. And the psychodynamic therapists were less likely to pay attention to the sadness and more likely to pick up on the shame and the anger. Okay? And it's not that the DBT therapists didn't address the shame and the anger, but they also were addressing the sadness. So there's just as many validating statements in both treatments, but what they're validating and when they're validating and how they're validating are different. Okay? All right, so our small conclusions from this were that it's important to look beyond base rates. You can't just take an overarching behavior like validating and assume that because two therapists validate the same amount, that they're actually validating the same things in the same ways at the same times. There's actually a fair amount of variability. And that the type of validation that's actually helpful might depend a little bit on whether we're addressing more primary emotions or more secondary emotions. And then finally, you know, the DBT therapists were more likely to do this blocking thing. Patients said, I was so angry with so-and-so for canceling at the last minute, that was so inconsiderate. The DBT therapist was more likely to say, yeah, it seems like you're pretty upset about that. I can see you're angry about it. Okay, notice the reflective part on that. And what about sadness? I mean, you didn't mention that. I don't know, I might be disappointed. Or what else did you notice? Or what did you miss? And actually try to block having 100% of the attention be at the end of the chain and try to help get the possibly easier to regulate emotion of disappointment, the possibly more authentic, more primary emotion, to become part of the conversation. Okay, so where do we go from here? Well, obviously we need to improve DBT. DBT is effective from one perspective, not as effective as it needs to be from another perspective. We need studies like these to identify mediators to tell us what to work on, and in-session studies telling us what's operating in the room to help us sort that out and do a better and better job. We have to understand these mechanisms and processes to improve treatments. And we can learn from other treatments. As other treatments identify mediators and central processes, we got to pull them in and do more of those things, because anything that's a mediator means that people need to go through that process to get to a better outcome. Now, a cautionary note about integration, because there's a tendency sometimes to hear, well, gee, DBT works really well over here, and maybe there's another treatment, say mentalization works pretty well also, there's good data on it, or whatever other treatments have data. Well, maybe we should combine them. And I want to suggest that that's a very difficult task, and we should approach it with great caution, because until we understand what the mediators are, actually we could lose the benefits of both treatments by prematurely putting them together. We have to understand what the mechanisms are before we can enhance and improve one treatment by understanding mechanisms in another. So that's a long, I hope, a long, slow process. If we jump too quickly, we could entirely lose what's meaningful. Okay, I think I'm out of time. Thank you.
Personal demonstration of DBT, and mention here that yesterday Ellen gave 2 seminars one to families who have a member with suicide attempts or self-harming, and another for therapists from the public service. Alan did these seminars as a contribution. He came, and thank you. And I would like to thank him very much for that as well. And we will hear now Alan talking with Dr. Yifat Cohen and Dr. Tzvia Zliegman. I will introduce them. And on Sunday we will see Alan demonstrating DBT with the actress Esti Zakheim. Dr. Tzvia Zliegman is a clinical psychologist and the founding director of Lotem Center for the Treatment of Sexual Trauma at the Tel Aviv Sourasky Medical Center. She is also the academic director and lecturer in Bar-Ilan University program for training therapists in the treatment of sexual trauma, as well as, sorry, cannot see, as well as in the trauma studies at Tel Aviv University. Dr. Yifat Cohen is a child and adolescent psychiatrist and psychotherapist. She is the founder and co-director, together with Dr. Nechama Pressler, of the OFEC Therapeutic and Training Center for DBT. Dr. Cohen is a lecturer at Tel Aviv University and the Israeli CBT training program. She used to be the director of the mental health in Netanya, and I welcome the three of them back to the stage for a discussion about DBT with one participant from the DBT, that would be Yifat, and another Tzvia, who knows DBT but does not fully, how would I say that, stem from that approach. Thank you.
Well, thank you for your wonderful presentation. So enriching. It will take me time to kind of process everything I heard today and yesterday. Yesterday, I was very impressed with your presentation, and I was really able to see your work. And I kind of wrote to myself different questions, but I actually want to ask you something more simple. When people come to therapy, they come because they suffer.
Right.
And they want us to listen to the suffering. Often they don't know exactly why they suffer, what they suffer from, what's bothered them, what happened to them. Often they can't talk about it because they don't have words for that. Often it's so a distance from them that they can't even conceptualize it.
Mm-hmm.
But very often they don't come to therapy because they want to, it's not, at least in Israel, of course they don't want to suffer, but I don't think, very often it's not the only reason why they come to therapy. They actually want us to understand them more. You know, they want us to listen to them, to help them understand themselves more. And they want us to be with them in their very private moments. And I wonder how DBT deals with that. You know, it doesn't, it bothers me, especially because I work with trauma patients, and most of our patients come after they suffer from prolonged, recurrent trauma for many, many years. And they many often can't talk about their traumas. They want to talk about their trauma. They want to understand what happened to them. They are very confused about it. And I found it that very often they don't want us to relieve them from their problems or from their pain, but they want us to help them understand their pain and their experiences. So I wonder what you think about it, and how do you apply DBT to treatment of trauma?
Yeah, well, that's a very good question. In DBT, I think we organize almost everything according to a dialectic principle, trying to both see change as a primary dialectic, but also we're always asking ourselves what's missing. What's missing from our understanding, the patient's experience, and what's missing from the patient's understanding of his or her own experience, too. Because there's an infinite number of ways to understand things, right? That's entering the concept world. So in DBT, we would say that with trauma, in order to do trauma treatment, of course the person has to have the experience that this is going to be useful and worthwhile, because doing trauma treatment is itself extremely difficult and painful. So there's an element of, there has to be some emotional ability to tolerate that, and there also has to be a cognitive understanding that it's worth going through this painful treatment experience to get to the other side. So we have to do a lot of things. We have to be very present, and as a human being, allow ourselves to be touched by the person suffering, on the one hand, but also have the skills to not get sucked into it too far and overwhelmed by it. Manage to find that.
Is it possible, really?
Well, I think so. I mean, at least sometimes, and the data would suggest it is. And that's part of why the team is so important. So we don't have this, what I think we sometimes call secondary traumatization for the therapist, or compassion fatigue, sometimes we call it. You know, we're trying to guard against that, because if we're too distant, at least in a DBT model, if we're too distant, the patient is not really feeling understood. In fact, it's not because it's not something just in the patient, we're really not understanding. If we can't, I mean, to hear about someone's trauma and not be affected by it means we're not really listening. And we're not really allowing ourselves to be in that moment. At the same time, if we only get pulled into that, we forget we're also the person's therapist. It's our job to help that person. Now, the data on trauma suggests that talking about the trauma per se is not particularly curative, right? There's actually specific things that have to happen. And so the therapist has got to titrate therapeutic presence and real, genuine, authentic warmth and caring and compassion with structuring and titrating and doing exposure and helping the person recondition trauma stimuli, okay? And the DBT therapist has to balance those two things in some way. Now, the good news is that we now have some really nice data specifically with very severely traumatized people in DBT. And in DBT, we pull Edna Foa's work in, which you're probably familiar with, you know, and we pull her work with prolonged exposure or other effective trauma treatments right into the middle of DBT. And DBT provides a context and some principles that allow the therapist to be meaningfully engaged. That's a short answer. I'm not sure I'm answering your question, but is that a start anyway?
Well, I'll continue.
Yeah.
I'll continue actually with this question, even though I had something else in mind. But you did the second stage of therapy, according to Marshall Linehan, is working on trauma. You did
well, that's a part of that. That's where that occurs.
The second stage.
That's not the only thing that occurs there.
Well, you called it emotional experiencing, the second stage, and if I would like you to elaborate a little bit of what kind of DBT do you use in working on this emotional experiencing, and if you can refer specifically to using other methods like prolonged exposure, because there is a protocol that Marshall Linehan and Edna Foa wrote about joint protocol for DBT and NP to work on trauma. So would you say that working on trauma has to be delayed or until there is the first stage goals are met, and only then work on trauma? And would you recommend using other methods in not only DBT work?
Well, what I want to say first is that when we use any aspect of behavior therapy, that is also DBT. So we're not making a distinction between prolonged exposure is DBT when that's the appropriate target. But of course we're pulling in all that we know from prolonged exposure research to do it. It's not truly, I guess you could call it an integration, but it's really not, because behavior therapy is already a consistent part of the foundation. Behavior therapy and Rogerian, therapy are both foundational in DBT. It's an acceptance and change are both foundational in DBT, both. So when we do either of those things, we are doing DBT if the timing is right. So in terms of, do you have to wait to stage 2? I think the data on this say that it depends on the setting in which you do treatment. So for example, if you have a safe environment, a day treatment or a residential program, and someone has very severe trauma problems, and that's the core of their problems, it's related to, say, suicide behaviors or dissociation or substance use, that actually if you have a very safe environment, right, doing trauma treatment increases arousal in many ways. It increases, therefore, danger with people who are doing dangerous things. So if you have a safe environment, the data would say that you don't have to wait until stage 2 to do it, if you have a safe environment. If you're in an ordinary outpatient setting, you probably have to help people develop a lot of safety skills, be able to manage that increased distress that comes from doing trauma treatment work. So it depends on setting. But I also want to add that, you know, if we look at borderline personality disorder, by the time patients come into treatment, somewhere between 1/3 and 1/2 have post-traumatic stress disorder. And stage 2 is for everybody, not just for PTSD. And so my shorthand of saying emotional experiencing is because that's what people with PTSD need to do. I mean, paradoxically, of course, that enormous, overwhelming fear is being truncated in PTSD. And so allowing people to do the exposure means that they engage in a more normative process of emotional habituation, experiencing, which helps people relearn the difference between, you know, thinking about a traumatic event is not the same as being traumatized. They're different things. In one, thinking about a traumatic event elicits sadness and grief and loss over this, as opposed to if it's happening right now, fear is very appropriate. So it's helping us recondition our emotional responses. But that's also true for non-trauma, which we also do in stage 2.
If not PTSD, so what do you mean by emotional experience in other patients?
Let's take, for example, someone that's quite different, someone without any PTSD, who's now in stage 2, is no longer self-harming, isn't trying to kill him or herself, but, you know, the same patient, okay, now she gets the SMS that says, the friend isn't going to have dinner with her tonight, okay? Now it's stage 2. So at the end of her chain is no longer self-harm, but it's this overwhelming sense of misery and loneliness that evening. So she's at home, she's not dangerous, she's not drinking to the point of harm, but she's just miserable all evening. So what we would say in DBT is that she's truncating her emotion. She's actually fighting the experience of sadness and loneliness. And that if she can tolerate the sadness and loneliness and manage it, then she can more effectively do problem solving. She can call another person. She can send an email to this same friend and say, can we reschedule for tomorrow? She can do problem solving, and if the friend says, oh, of course I could do it tomorrow, that's going to reduce her sense of loneliness. Having someone to go have dinner with tomorrow may not be tonight, but I'm not as lonely tonight knowing I have something to do tomorrow. So actually allowing the person, and this of course is the hallmark of DBT, is seeing emotion dysregulation as the central avenue through which we go to solve problems and improve life.
So it's generalization of skills mainly.
Absolutely. Still, stage 2 in DBT is still exactly like DBT. There's nothing non-DBT about it. It's just that the targets, instead of being safety and stability related, they're misery related. Yeah.
I would like to ask one more question about I guess the basic assumption is that there is continuity in the sense of self in DBT. And since I have been working with a trauma patient who very often get the diagnosis of borderline personality disorder.
Right. And they're dissociating.
And they're dissociated. And the whole structure of their personality is dissociated, and their most basic experience in the world is being kind of discontinuity, not continuity.
Right.
I just was looking at the chain analysis that you've done, and I wonder how many of my patients were really able to make this, even make with me chain analysis now, because very often they're in different self-states when they are, for example, cutting themselves, making a suicide attempt. They often can't reflect on it. How do you deal with dissociation with DBT?
Oh, that's a great question. Can everybody spend, do you have about 2 hours for this? 10 minutes, okay. So there are two parts to this. One is you talked about this self-states, or and DBT we would just frame it slightly differently. We would talk about this as self-behavior, okay? And so the very short version of this is if you think from a DBT perspective, what is a self? Okay, and this is I'm going to give you a very strange answer, okay? That's, at least if you're psychoanalytically trained, it's a very strange answer, okay? Because there's no unconscious process in DBT, no dynamic unconscious. But that doesn't mean that there aren't things that are not in our awareness, they're just not purposefully, okay? So if you think about a self, I would say, I'll just say to you, so are you sitting or standing right now? I know, simple, trivial. Are you standing up or sitting down? Okay. Now you have to be a very, very fragile, very dysregulated, very easy to dissociate patient. Okay. So that's, even though it's a silly question for you, it's not such a silly question for someone whose self is fragmented, right? So are you standing up or sitting down? That's not a trick question, really. No, you're not dissociating. I haven't provoked you yet. Don't dissociate yet, for heaven's sake.
You know,
No, play it out with me. Go ahead.
You want to play it out?
So, are you standing up or sitting down?
If I am, you want me to be Tsivia?
Please. I know, but that's okay.
It's not an easy answer.
But she still knows she's sitting down. This is not a trick question. No.
But you know, the moment you ask me this question, I'm already in getting into a different self-state.
That's okay. That's okay. But you're a patient, right? Your patient isn't thinking that way.
Oh yeah.
No. Your patient doesn't have the concept of different self-states, right?
I'm intimidated by you.
That's okay. That's okay.
That's what I feel.
You're feeling okay. So, right.
And so I say, okay. So think about it. But, well, the question, because I'm sorry, can't think about your questions because I'm already not here. You know, it's like the moment you approach me this way, I immediately in a different place.
Okay, so I would say then what just happened? What just happened? Because you were looking at me a minute ago and now you're not looking at me so much.
Okay, so let me sit the way my patient would sit.
Yeah. So, did we just meet? Did we just meet? Because you're acting like I'm a dangerous person and I thought we knew each other pretty well. Could you bring your attention back to me? Right?
What do you want from me?
Could you just notice that there's nothing bad going on in the room right now? Remember the mindfulness part, paying attention?
I don't understand you. What?
Okay, go ahead and stand up. Stand up. Stand up. Come on, stand up. Get your ass out of the chair. Take a deep breath. Okay, now look around. Okay, I know you feel terribly. No, look up at me. Because this is terrible. You feel terrible right now. But I want you to, no, look up at me. Come. I need to trade chairs with you. I need to change. Okay. Come, have a seat. I'm assuming that we've had some sessions before. I wouldn't do this the first time, okay? All right, now I want you to notice, okay? Notice you're feeling really scared right now. Right, you're feeling really scared. But I want you to notice, look over here, look over here. There's nothing dangerous in the room. Yeah, okay, but before you go, come back here for just a minute. Come back here for just a minute before you go. Come on, come on. Nothing bad is happening here. Come on, come on. Okay, pause for just a second. This actually works in real life because I have about 10 minutes, okay? But I don't have 10 minutes now. What I've got to do is help her use a skill that we would have already talked about, which in DBT we would call mindfulness. And mindfulness of the present moment would be becoming aware that even though it's just like the car accident example, there are very good reasons why you feel scared, but they aren't because there's anything dangerous now. That's the fundamental discrimination I've got to help her with. Now, if you're a person who dissociates easily, I'm going to start much slower. I would know that. And I'm going to start much slower with things that are provocative but aren't going to get you to feel that scared. I'm going to have to start, I'm going to titrate it differently. Okay? So, and that's the fundamental process. Okay, now that's not enough because self, you know, okay, so then I would say, so now it's roll the clock forward 3 sessions later, and I say, are you standing up or sitting down? You can say, well, I'm sitting down. And you may be a little scared, but you can do it. And then I say, okay, now that's your wise mind. You know that, right? It's not a tricky thing. You know you're sitting down. Who's, by the way, who's observing, who just did that? Who's sitting down? Honestly, this isn't meant, this is, you're getting, you know what, you spend too much time in concepts, okay? You know, in America we have, you know, every culture has its sages. We have a sage, Mark Twain. He said, you know, don't let, okay, your school and your concepts get in the way of your education, okay? Like, don't get too stuck in those concepts in your head. They're just concepts. They're not reality. This patient's reality is fear in a non-dangerous situation. That's a problem, okay? And so what I'm going to try to do is help recondition your brain to not be so afraid in a non-dangerous situation. So I've got to make this explicitly safe, and then I've got to help you become increasingly aware of its safety. And from that context, we can then work on what you would call self-integration.
So you actually think.
Do you want your chair back?
Yeah.
Okay.
Thank you.
Sorry. Thank you for being flexible.
So you actually think of dissociation as another behavior.
It's another escape behavior. I mean, dissociation is the perfect prototypical escape behavior, right? One doesn't dissociate because it's fun, right? The only way that one would dissociate is if what they're leaving behind is worse than nothingness. And nothingness is about as scary, I mean, what could be worse, you know? So that's the paradigm. It's an escape paradigm. It's completely consistent with dysregulation. So if you're cutting and dissociated, the chain wouldn't be on the cutting, what you say, I don't remember. The chain would be up to the last thing you do remember. That's the chain you can do. And then we'll help you learn skills to bring your arousal down to make it less likely that you'll dissociate. And then over time, we'll be able to do a chain on the self-harm. Or by the time we get there and we help you stop dissociating, you won't be self-harming anymore because the same things you need to do to not dissociate are the skills that you need not to self-harm. That may take a very long time, right? I mean, there are many stimuli to make you feel terribly afraid and overwhelmed, and it's going to take a long time to help you experience that it's safe. But it is safe, and I am going to do things like tell you to get your ass out of the chair, because that's a little jolting, and it's like, this is a safe place.
But sometimes the safe place is the most dangerous place, you know.
Well, I wouldn't say that. I would say I'm not going to buy that. I'm going to say it feels very dangerous, and it's not. I get how it feels, and I want to understand why it feels that way, but I'm not going to acknowledge that this is not dangerous. I'm not going to assault you. There's nobody who's going to assault you here. And that's the dialectic. There's a piece of it that's valid in your history, but it's not valid in this moment, in the present. And that's the discrimination that we have to help you with.
It's really helpful.
Okay, thank you very much.
Oh, it's a pleasure. Yeah, thanks.
Thank you, Professor Fruzzetti. דוקטור זליגמן, דוקטור כהן, תודה להדגמה. Probably we got some a preliminary taste of what is expecting us Sunday.
Great.